here to talk to you. And it's a real honor and a pleasure to be here this morning. And my job is to increase the awareness or educate you on what pulmonary hypertension is and what's out there. So, a little disclosure, I owe a lot to my patients and their families, so I'd like to dedicate this lecture to them. And I have no financial conflicts of interest to disclose. And this is just an education, so if you have questions from this, I'll be able to answer, but I think you should go back to your provider if you have any specific questions with regard to you particular, and don't take this very personally, it's just more for awareness, okay? Awesome. So, just before we go more deep into this, how many of you by a show of hand count know what pulmonary hypertension is? Beautiful. So, those who know, bear with me. Those who don't know, I'm going to walk you through it. So, a little more basics that we should understand is if we were to take the chest wall away, the left lung, the right lung, and the heart is seated in between. And if one was to dissect the heart or slice the heart halfway through, you'll see that there is the right side of the heart and the left side of the heart. So by convention, the right side of the heart carries venous blood or dark blood with carbon dioxide and depleted of oxygen. So it's denoted in blue, and the red is the oxygenated blood that's denoted in red. So the blood from the rest of the body comes to the heart pumps the blood through this blue trunk into the lungs, where there is gas exchange, and then after oxygen is picked up and carbon dioxide is dumped, it comes back to the left side of the heart, where the heart then pumps it to the rest of the body to deliver oxygen. Now, you can see in this small insert here, at a microscopic level, the small little bubble wraps around which capillaries are arranged, and that's where the gas exchange occurs. So we just finished medical school. Now, we're going to the definition of hypertension. Okay? So, hypertension is high blood pressure on your arm as your doctor checks in your office, and that's a result of the left side of your heart pumping through. Now, pulmonary hypertension on the same token is high blood pressure in the lungs, or the circulation in the lungs. However, it's not as easy to try a blood pressure cuff around the lungs, but we'll see how we can measure it and how we can estimate it. Now, one misconception, not only among patients, or it's also a very big misconception in providers as well, where we think, the high blood pressure is the problem, but it's the other way around. I think the high blood pressure is a consequence of a downstream problem. So if you see a normal blood vessel and then an increased resistance blood vessel, so someone like stepping on the garden hose, and then the pump is trying to pump harder again, and that hard pumping shows elevated blood pressure, and that's what is called pulmonary hypertension. Now, if on the same token, the same example that I showed you, if one was to cut the circulation into, pressing the wrong button, if one was to cut the heart and lay it on the table, the right side of the heart, the big blood vessels that take blood to the lung circulation here, the blood circulation going back into the heart, and the left heart. So there are about 40 to 50 different causes that can cause pulmonary hypertension. And each of them can involve any of these areas, and depending on how and where they involve and their response to treatment and their pathophysiology, they are bundled into these groups for providers to triage and say, hey, these are the patients whom I can treat, and these medications and so forth. But then, interestingly, sarcoidosis falls in this group of miscellaneous. As you can see, I'll explain you why it's in the miscellaneous. It's because there is more than one reason why people with sarcoidosis can develop pulmonary hypertension. And some of the things that we don't know, and that's where our challenge is. Now, I have to admit, I've copied this exactly from Dr. Baughman's article. I think I need not reinvent the wheel. It is a nice review article from 2017, Dr. Slobin and Baughman. They did a very excellent job of putting everything in one place. And as you can see, it's very complicated. So a patient with sarcoidosis can have pulmonary hypertension due to this, 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 or a mixture of any of these components. So it's as we work up a patient and engage with the patient, it's our job to elucidate which mechanisms are involved so we can give the right direction for treatment and help to the patient that we are dealing with in an individual. So vasculocentric means within the blood vessels. So as you can see here, the blood vessel that's supposed to be like this in a nice round circle has now become a straw-like, if you will. Here the lumen is so narrowed, and you can see small, like Dr. Obi was mentioning, granulomas. They're in the blood vessels and they cause blockage. And so if there are things blocking in the blood vessels, then we need to try to give medications to relieve that blockage. If, on the other hand, you see the lungs, here, this is the CAT scan and this is a chest x-ray, and all this white hazy in between is scarring in the lungs. So if there is advanced disease, scarring, and that's causing kinking in the blood vessels, then again the pump is pumping harder. So in that instance, while we help medically, probably lung transplant would be a better choice. And then, if there are comorbidities, we obviously, I think Dr. Brian Houston is going to talk about cardiac sarcoidosis, so I won't take his thrill away. And that's the cardiac MRI. And if the center of the chest here is called the mediastinum, that's what tethers the lungs and the heart in place to do their job and supports the structures. Now, sarcoidosis by general is granuloma, inflammation, scarring. So if there is scarring, then that can compress the big blue trunks that we saw initially and cause high blood pressure. So if there is a stricture in one of those vessels, then a doctor can go in and put a stent there to open up the kink and help blood flow smoother and easier. So, now, sarcoidosis itself, we are struggling with, there is no awareness, it's a little rare disorder, so we have to get into the limelight. I'm struggling even more. Sarcoidosis associated pulmonary hypertension is even more, I guess, in need of help. No? So we'll try to work on that. So how common is it? So it's, I think, a lot under-recognized. It's not recognized as often as it should be, I think. And the reason I say is from the studies that we have so far, the incidence is anywhere between 20%, 6% in the community, 20% about in a referral center. And if you put people on a treadmill and see if they have pulmonary hypertension, it goes higher from a very old report. Now, if you go to a transplant center and sample, the incidence or the prevalence of disease is as high as 75%, meaning 2/3 of patients waiting for lung transplant due to sarcoidosis have pulmonary hypertension. So, does it really matter? And I think yes, it does matter. And the reason is, it's associated with increased mortality. So, African Americans on an average have a 2.5-fold increased mortality for waiting for a lung transplant while they are waiting. The higher the pressures in the heart, the more the mortality. And this is a nice curve. We call this the survival curves in medicine. And even from, I put this here because it's very easy to appreciate. And it's a study that compared different modalities of treatment for sarcoidosis, pulmonary hypertension, and they compared the outcomes for patients with sarcoidosis, but those who don't have pulmonary hypertension, and patients with sarcoidosis and who have pulmonary hypertension. So the curve down here is for people with sarcoidosis who have pulmonary hypertension. As you can see, as time goes on, the number keeps dropping, meaning people passed away. And people on the top are people with sarcoidosis, but they don't have pulmonary hypertension, and they live longer. So it does matter, and it's something that we should take it seriously. What happens is as there is increased blockage and the pump is pumping harder and harder, at some point, the pump is going to say, I'm sorry, I cannot help more. It starts failing, and that's when you start seeing the clinical decline and heart failure. Now, signs and symptoms. Dr. Robi just mentioned, and Ms. Kelly also mentioned that we need more symptoms and data to prove what symptoms are there for sarcoidosis. But then, the problem for sarcoidosis pulmonary hypertension is these are very non-specific, meaning they can be due to sarcoidosis, they can be due to lung involvement, they can be due to muscle involvement and everything. So they don't necessarily, although they are very important clinically for you and me, they do not say, hey, this patient sarcoidosis pulmonary hypertension versus this patient doesn't have sarcoidosis associated pulmonary hypertension. So they're not very specific or guiding in that sense. So the biggest questions come up, like how do we sense? And I think although the information that we have so far is non-specific, the routine tests that your doctor gets for you will give clues to suspect that there might be sarcoidosis associated pulmonary hypertension. The bottom line is there should be a high index of suspicion to say there may be an underlying high blood pressure in the lung circulation. Now, if you have a chest X-ray, more likely than not, or on a CAT scan, you'll see scarring on the lungs, which predicts that there could be sarcoidosis associated pulmonary hypertension, or on what we call the 6-minute walk distance. I know some of you raised your hands for 6-minute walk distance, but what that essentially is, we put an oxygen meter on your finger and ask you to walk around for 6 minutes in the clinic while we watch it. So how is your heart responding, how is your oxygen in the body doing, and how much distance you walk give invaluable information to tell me which organ is struggling most. Is it the heart, is it the lungs, is it a combination of both? And it's called a submaximal exercise test. It's like you're walking to your mailbox, it's you're walking around the grocery store, and what's happening there. So if you feel symptomatic there, that means you know that there's something happening. So reduced distance that you're not able to walk, I think less than 300 meters, if your oxygen level drops or you're needing supplemental oxygen, that could be additional clue that there should be efforts to rule out pulmonary hypertension that's lurking underneath. And if you have a CT scan, enlarged right side of the heart that we just saw, pulmonary artery enlargement and lymph node enlargement causing kinking or pressure on the blood vessels, in advanced fibrosis, all these are again signs that the physician should think about sarcoidosis associated pulmonary hypertension. Now, once we entertain the possibility of it, the two tests that can help you, suspect that you have sarcoidosis associated pulmonary hypertension, you can get an echocardiogram, which is an ultrasound of the heart, which is non-invasive, no radiation. It's like they do the ultrasound for the babies and then show the heart structure and function. So that's an easy test, very reproducible, but it's not as good if you have advanced lung disease. MRI, it's a better test, but again it's associated with claustrophobia. If you have a pacemaker, you cannot get it. So, I mean with the older pacemaker. So, like I said, it's a high index of suspicion, and the treating provider has an outline or a framework to follow through. So if there is no scarring and the symptoms are not being explained or not responding, especially your dyspnea or difficulty breathing, chest pain are not responding to prednisone and other medications, or you have advanced or fibrosis on the imaging study, then you suspect you have pulmonary hypertension. You go down this path, you get an echocardiogram. If there is anything that's inconclusive or if it's suggestive of, then you go for the gold standard testing or invasive testing. If you do not, then you continue to monitor. So the gold standard would be a right heart catheterization. It's a same-day procedure. You come into the hospital, it's relatively very safe. It should be done in a center that does enough of them to make sense of the numbers that come through. So the doctor goes through one of the big blood vessels in your neck or groin and goes into the travels through the heart into the blood vessels of your lungs and gets these numbers called hemodynamic data for us to make sense. So this either confirms a diagnosis or refutes a diagnosis of sarcoidosis. And then, coming back to the same analogy that we spoke earlier, are your symptoms due to sarcoidosis or sarcoidosis related pulmonary hypertension or a mixture of both? Which intervention is making difference in your symptoms? Should I escalate on my pulmonary hypertension medications, or should Dr. OB increase their sarcoidosis medication? So it's not an easy decision that we should take. I think it's a multidisciplinary involving the patient and provide care. And like Ms. Kelly said, none of the outcomes that we measure are set in concrete. For example, 6-minute walk distance is not really helpful in patients with sarcoidosis, or it may underestimate, or it may not be a good marker to follow, and we don't have good outcome measures as of now. So as I spoke, if you have vascular problem, I'll show you the medications we have. There we spoke about lung transplant. Here is treat the underlying conditions. And there we can put a stent is what we spoke about. That be tailored to the patient in particular. So recently, and I think thankful to all the research that has gone on, all the awakening that has gone on, people showed interest, and thank you all for participating in the research, is we have about 3 classes of medications that are used in other forms of pulmonary hypertension, have been tried, at least experimented in sarcoidosis associated pulmonary hypertension. But as the reason I wanted to put it here is the number of people involved in the studies were so small, so we cannot really make a good conclusive decision of what those drugs and the outcomes. So I think there's more research needed is the bottom line. We use these medications, but it's at an expert center, and we don't have a confirmatory evidence as yet. Lung transplant, especially if you have pulmonary hypertension, it increases the chances or allocation score, so it should be considered for people. So until, like Ms. Kelly was telling, until the past, it was all gloomy, dark, nothing there, right? But in the next coming, and I think we're in a prime time, and I think this is how it's going to look like. We should hope for bright, and I think things are on the brighter horizon here, okay? And now, and the reason I say so is there's a lot of interest. So if you go to clinical trials, there are about a registry and about 3 or 4 clinical trials lined up, and another pharmaceutical industry giant interested in doing research in sarcoidosis associated pulmonary hypertension. So I think we're getting there. And this is the clinic I practice in, and ECU, Dr. Thomason and Anaga Malur have a murine model. We try to overlap human and animal sarcoidosis model and see if we can come up with tools. So a lot of things happening, and these are some selected resources for you guys if you are interested. And this is the article I was talking about. It's from 2017. It's a very nice and well-written article. And with that, I want to say thank you.